Okay, we're going to move into the case presentations again. Last year we had 1 hour of case presentations, and I thought that was a really, really good part of the whole process. Unfortunately, it's not coming out very well on the website because people were not using the microphones in the audience, so we didn't hear very much. So it's important that we do use the microphones. We're going to have our two fellows present the two cases again, and then I'm going to ask all the experts to come up onto the stage here, the pseudo stage here, and we're going to discuss about how we would deal with this and see what happens when you get to people that are world stature dealing with the same cases. Okay, we'll ask Khalil to start first.
Yeah, hello again. Just a quick review for that patient. It's a 56-year-old man with a completely healthy history. After 1 month of hoarseness, he got a chest X-ray diagnosed with a large mediastinal tumor. The situation is he got, after this, 5 cycles of chemotherapy, CT scan, MRI. After this, it didn't show any shrink of this tumor. Extensive discussion was done with that patient, and at least we decided to take them in the OR and do surgery for him. Bilateral clamshell incision was done. The tumor was resected completely, and a small pulmonary artery was resected too, because if you see that picture here, the tumor was behind the pulmonary artery, and we should dissect it to take it out. What's happened in the CT scan and the MRI didn't show any metastatic disease. I showed you that too, but I spoke with the radiologist after in the OR. They found an unexpected lymph node. They cut it out and sent it to pathologist, and he said, okay, as you see here, it's metastatic from that tumor, a malignant spindle cell. When I spoke with the radiologist, he told me it was a very big, huge tumor. That's why they couldn't see any lymph nodes at that part. Unfortunately, it was a R1 resection. It isn't a R0 resection. As you see, it was with a positive margin. The patient was, the operation was on December 9th. He was discharged already 2 weeks ago home. He is stable, fine home, but the discussion now is what we are going to do with that patient. Thank you.
Okay, that's the recap of the first patient. It was a long operation, but the 3D reconstruction, which is, as you probably may have guessed, right here, and that's the patient that's the drawing that's on the website. The 3D model helped us absolutely tremendously. It was a tiny bit off, but in general, it even told us that we had to resect some of the pulmonary artery and some of the pulmonary vein was involved. It was amazing. Before this tumor 3D reconstruction was made, I had no idea if I could resect this. I was asking me to resect it. I had no idea at all. I went down with the radiologist and I spent a half an hour with them. They showed me this view and that view, and I'm going, okay, I really don't understand. And that's why I went to Assad. When I went, I had heard he was doing some of this preliminary stuff a few years ago, and I asked their group to make 3D reconstruction, a model for me. There was a patient in Brazil. I went down, he had a sarcoma. And a usual story, Mike Reardon knows these sorts of things. We're going to let him die. Wait, I know. But I used it to go down there, and when I went down there, the radiologists thought they understood the tumor until they saw the 3D reconstruction and the 3D model. And it really helped a lot with discussion with the family, actually. I think it helped me tremendously to understand whether I could resect it or not, and it also helped the discussion with the family. When I gave this patient this model in my office, he really started understanding why we were having a hesitation to do an operation and why he was going to see so many experts to have the resection performed. So I think if you're going to use these things in your own practice, use them to understand the tumor, use them to identify whether or not the patient is having a response to chemotherapy, but also use it to talk to families, because they really, really, really understand what it is, part of the heart that you have to remove. You know, we had to remove, this thing's wound all around the great vessels, the bronchus, and all that sort of stuff. So that's the first case. It was a successful resection. However, as you saw, we found this big thing at the end. What the heck is this? A big lymph node. It was a station 4L. And the pathology showed us it was a positive resection margin. So that's the first statement. Unresponsive tumor, we think. We don't really know.
Unresponsive to Adrian phosphomide?
Yeah. Albie can go further. Wait. Not without the microphone. But the question was unresponsive to AI.
So I think the term unresponsive may mean
Different things to
things
different people. It didn't shrink.
Correct. So on radiology, it didn't shrink. But
It
the
didn't
patient was significantly better. His pulmonary symptoms, his hoarseness, his tumor pain all went down tremendously. So there was a bit of a diagnostic dilemma because when I saw him, my main aim was to get a Maga scan and start his chemo. It elapsed on my mind that his scans are but nearly 3.5, nearly 4 weeks out. So when we did the first scan, it showed disease progression. So I think Charles, if he's here, he'll remember the exchange of emails. So I sent an email quickly and say, hey, can you guys resect this? We need to discuss this. Then an afterthought came and I said, you know what, we haven't compared the scans properly. So we spoke to the patient again and his symptoms were convincing that he was better. So we bit the bullet and we went ahead. I gave him another 2 cycles and rescan him and it is stable. So in all retrospect, I don't think that his disease progressed. If anything, I think he had a minor response. But truthfully, with the type of tumor that he had, we didn't expect significant shrinkage. I think we would have done well by just stabilizing the tumor, which I think we did.
Yeah, I don't know whether we should have the discussion now or present the second case. What do people want to do? Should we get the panel up here now?
Yeah, might as well discuss this.
So why don't we get the panel to come up now, and I'll ask different people different questions. Come on up, everybody come up. Everybody who spoke. That's your, yeah, come on, everybody come on. Remember, use the microphones. What's that? Are we missing one chair? Don't forget to use the microphones in the audience. So Azad, I showed the case that we did this reconstruction. Can you talk to us about some of the challenges or the ease of making that, some of the challenges you had with respect to doing that, or when we come to you with these things? Just talk to us about the reconstruction, 3D rendering, because you actually performed 2 3D renderings. One was a 3D model on the computer. It made us understand a little bit more, but until we actually got this model in my hand, that's when we understood that we could actually resect it. Then it was a no-brainer that we could resect it.
So for this one, we had 3 retrospective data sets. We had a cardiac CT, which is the one we segmented first, but that only had sort of a sphere around the heart, so it was missing the part that went up to the great vessels. And the other source that we had was an MRI, but unfortunately the slices were too thick, and then we had to use a thoracic CT to actually get this final model. The limitation was that we couldn't get the myocardium very well because of the motion artifact and the fact that it's just naturally difficult on CT. But the part that was of most interest to both the thoracic surgeon and Dr. Cusimano was the part surrounding the great vessels. And once we were able to actually do the rendering with the tumor transparent or the tumor solid, the heart transparent, that seemed to be quite helpful for Dr. Khashoggi to be able to kind of visualize what was happening. And then with the printed model. The printed model was a bit challenging because we wanted to have the tumor transparent, which didn't quite work out. And we wanted to sort of make it in a way, because one of the questions was, can the tumor come out in one piece? Because obviously the preference was not to have to cut it. And one of the things we wanted to try was to see if we could computationally model what the least number of slices would be that you could cut it in to get it out if you had to cut it. That was something that we discussed. We never actually managed to do that, but that is the kind of thing that you could potentially do down the road for complex tumors, is calculate sort of certain geometric optimal cuts. And that kind of information may be useful for radiation as well, or something analogous to that. May have applications there.
Anybody else want to pipe in? This patient had when you talk about knowledge, this patient came to us from an outside institution, and they had done an anterior thoracotomy to get a piece. That's an example of education of the public. We could easily have taken a transcutaneous biopsy of this thing very, very easily, especially it wasn't even attached to the heart.
Can I ask a series of questions?
Yes.
So I find the case presentation to me doesn't ring right in my ear. So first question is, was there lymphoid tissue around the lymph node that actually proved it was a lymph node and just not a soft tissue mat? And second, since you were able to take out the whole tumor, why don't we have a diagnosis?
I'm not a pathologist.
No, but like everywhere we go from here matters, because pathology is still everything. I mean, is this a melanoma of unknown origin that met into the heart? I mean, this is, are we dealing with the right disease?
So I can talk to you about the first question that you had. Was this truly a lymph node? It was in the place where we found a lymph node, a classic place of a lymph node. It didn't look like lymph node at all to us. It was like a separate little hunk of something where the lymph node should have been. And we said, holy smokes, this lymph node has been completely replaced. And it wasn't a small lymph node. It was, 5 centimeters by 3 centimeters by 2 centimeters. It was a considerable hunk. And one of the questions we had was this a little satellite lesion not attached to the rest of the lesion? You see, the lesion came out in one piece. I should have shown a photograph of the actual lesion. It came out in one piece. It was not infiltrating any of the great vessel or heart. But this was a completely separate lesion, completely separate from the whole process. And when we had finished removing the thing, when we were sewing up his vessel again, that's when we realized there was another little hunk there.
Because the real reason I ask is if this turns out to be an amelanotic melanoma, you know what to do adjuvantly, right? And this is just not ringing clear to me of what we're actually dealing with once you get to medical oncology.
Was the lymph node the piece that you said was not captured in the model? Because there was a
It wasn't
piece,
captured
you said
in
there was
the model.
something that we lost. We didn't catch in
It was
segmentation.
literally, I can show you in the model where it
Yeah.
was. It was literally right there. Let me
Right
see
behind
here.
it.
Oops.
Okay.
That was curative.
Just speaking to
It's not
the
that easy to
diagnosis.
cut the heart out. It's literally
Can't believe you broke the model.
I
you know,
resected the heart.
from the pathology point of view, in terms of the diagnosis, it wasn't my case. I can't speak to what stage of diagnosis it's at. Frequently, every immunohistochemical stain in the world on sarcoma will still end up at, I'm sure it's a sarcoma. This would be an example of where molecular might be helpful. You're probably going to end up at high-grade sarcoma. It didn't look pleomorphic in the slightest on the one image I saw. So high-grade spindle cell carcinoma is the classic I don't know. But molecular would be very useful in terms of whether or not a trial would be appropriate. I don't think we have any targeteds that are approved. But the other thing I would say is if they got AI already, it would be interesting to look at what degree of necrosis was in there. Tumor necrosis does look subtly different than treatment necrosis. So especially because originally it just didn't look that necrotic. It looked like a healthy spindle cell sarcoma. It'd be interesting to see what the response was. Granted, that's not validated in sarcoma and pathology at all, but it's an interesting question to ask because with an N of very small, you may as well go with what information you do have.
So the specimen, both the initial diagnosis and the final pathology, was reviewed not only here, because that's the flow of the information, but it's also in our sarcoma reference lab, which is in Mount Sinai. So that's the first thing. And I couldn't recall the exact details, but I'm sure like S100 was negative. But, you know, the cocktails of immunohistochemistry is very high. This patient, because we realized this is pretty much a systemic disease, was profiled by an province-based program called Octane. It's about 200 genes, including NTRK, and it does not have any actionable mutation. The comment from our pathologists at the time of diagnosis, when they called this an undifferentiated spindle cell, we always ask the question is this because you don't have enough? Or and their answer is always standard that more is always better, but unfortunately in this case it didn't actually change the diagnosis.
I think it weighed 1.7 kilograms.
And you rolled out synovial sarcoma.
Yeah.
So I think these bland, high-grade spindle cell sarcomas do occur in the heart, and that may actually be the diagnosis exactly as listed out there. And if it is, we're still faced with a situation where there is a margin-positive resection without a very clear understanding of how much of necrosis was actually induced. There was some symptomatic benefit, which I take into account with a great deal of gravity, because if the patient is beginning to feel better on AI is not something I come across very often, because usually they feel like crap once you start the chemotherapy. It's actually pretty toxic. So if someone is actually feeling better on a drug that causes most of their hair and body parts to fall off, it's usually a fairly good indicator that there is some degree of response. But it still does not fix the R1 issue that comes on board. So if the surgery was more than 6 weeks away, I would certainly look at re-imaging, especially re-imaging with a functional strategy. I know I'm biased in that standpoint, but it is very critical to find something measurable at this particular point, if it is available, so that it can guide the rest of your therapy going forwards. If that functional scan comes back as completely negative, and it is a young 57 who's in best shape.
He is.
Yeah. And I would still try, and the percentage necrosis is on the lower side, not a whole lot of necrosis, not much of an immune infiltrate into the tumor. Try gemcitabine and docetaxel as a way of trying to ward off this from coming back. I know there's no data to support it, but in good performance status patients, the odds that you can actually push microscopic disease that is still present into a state where it doesn't recur is a lot higher than waiting for it to recur, which we know from all our data is certainly going to happen, and then trying to treat it unless you're planning on taking it back to the OR again for a resection downstream.
Yeah, it was an R0 resection. Go ahead and speak about the functional. Say what you want, but I also want to talk about how you would look for it.
No, I guess my question though is how R1 positive is this? Is it just?
No, I think it's an R0 actually.
It's an R0.
I'm pretty sure it's an R0. Oh, not R0. No, I'm sorry. R1. It's R1.
Yeah.
And is it a high grade tumor or not? Like like all of this matters in my ear. Like, is this one of these slow growing indolent tumors, or is this like 10,000 mitoses per high power field?
I cannot recall on top of my head.
Yeah, so the pathology report was just said malignant spindle cell tumor.
Yeah.
There wasn't much information on the pathology report. He had hoarseness.
No, the grade has to be. I mean, I think
grade,
that
it is high
you
grade.
have
Okay,
to
no,
insist.
I'm just-
It has to be high grade.
But
so.
I cannot recall a specific mitosis.
Oh, that doesn't matter as much as.
Yeah.
Well, but I mean, with a spindle cell neoplasm that doesn't look overtly necrotic by pre-operative measures, it would almost have to be driven by mitotic rate to rate a French, American, British high-grade score.
Was it this case where it was 18 or something, or was it the next case? I don't recall. What was the mitotic rate in this
It was
particular?
It's the next one.
It was the next case.
That was the next case. Sorry.
The patient had hoarseness for, if I remember correctly, almost a year, and his hoarseness did get better. But when we accidentally nick something in the OR, when a person gets vocal cord palsy after cardiac surgery, usually see anesthesiologists. No, I'm just joking. But when they get hoarseness, their vocal cord does come back as they get further and further away. So the hoarseness probably was related to just recovery of his paralyzed vocal cord because he went to the OR hoarse.
I guess my next question is there a radiation option based on where the positive margins are?
Okay, I can speak to that. It would certainly be nice to have a 3D model now that the tumor's resected that showed us where the positive margins were. That would make radiotherapy much easier. Without that, we wouldn't know where the positive margin is per se, but it also probably wouldn't matter a great deal because we would treat whatever area the original tumor occupied, or at least within the boundaries of wherever the tumor originally was. And I think if the concern for this patient is primarily local failure at this point, then radiotherapy makes the most sense, more sense to me than a second type of chemotherapy. If the concern is, if the concern for systemic failure is greater, then perhaps radiotherapy, blasting away in his mediastinum at this point doesn't make a lot of sense. We don't know, obviously, if or how this patient will fail at this point. Most of the evidence for the effectiveness of radiotherapy, the only randomized evidence in favor of radiotherapy comes from extremity sarcoma, from trials that were performed in the 80s and 90s, which showed that in limb-sparing resections, the addition of radiotherapy markedly decreases the risk of local failure. In extremity sarcomas, adding radiotherapy to limited resection has a local control rate of greater than 90%, at least, in high volume centers. And the real problem that we're faced with is a failure to control disease systemically. So in this case, when I see a patient who has not yet failed metastatically, sure, there is a lymph node involved, but like we've mentioned, maybe that was just another tissue deposit or something. It's not proof of systemic failure at this point. I would advocate for radiotherapy because right now the patient still has curable disease, and we shouldn't just wait for it to recur in the mediastinum. We should treat with radiotherapy until we know that local failure is not his biggest risk.
When would you start?
6 weeks after the operation.
And why
I
do
would
we-
want to see the patient 2 weeks after postoperatively, at most 4 weeks, so that I could plan to start 6 weeks.
Why do we choose
afterwards.
6 weeks?
What?
Why do we choose 6 weeks? It's always 6 weeks. Is it because you want our wounds to heal, or is there?
Yeah.
That's
yeah,
what it
because
is.
it's a stupid convention. For other tumors, we wait 4 weeks. For the brain, for intracranial tumors, we start as quickly as 2 weeks. This is more analogous, probably shouldn't say this, but it's analogous somewhat to like a retroperitoneal tumor. Well, probably most of the people in this room know that the recently completed Trachon Trial failed to show a benefit to radiotherapy in retroperitoneal tumors. So that was neoadjuvant radiotherapy, but a lot of the same principles probably apply. So, I can't say that there's strong evidence for a benefit of radiotherapy in this case, but radiation kills tumor cells, and if there's micrometastatic disease in his mediastinum, which there almost certainly is at this point, we should give him radiotherapy so that at least he doesn't recur here.
What dose would you use in this setting? Would you use a standard?
I would use the post-op dose, 66 gray.
Oh, okay. And
it's certainly safe. Do it all the time in lung cancer.
Okay.
And you can, cure early stage lung cancer with that dose. And
So did you say 66?
yes.
So I think that one of the reasons we were playing around with the staging system, and this is like the right patient to talk about, why we were playing around with the staging system for sarcoma, is even though it got switched back, N1 positive disease, which is probably has nothing to do with a lymph node, it's just a local regional something or other. The reason it became stage 3 was to encourage surgical aggression for local regional disease and aggressive management of local regional disease, which was why, I think he needs radiation before chemo, and I am terrified of gemcitabine after radiation. And so I think where I am is game over, radiate away, and I'll deal with it afterwards when he becomes distant metastatic. Because if he's going to die, it's going to die soon of his local positive margin.
In our center, just said we would actually do the chemotherapy first, and at the tail end is where the radiation would typically fit in. Partly because of this radiation recall situation.
But not in a patient who's had neoadjuvant chemotherapy.
Actually, we use that for our neoadjuvants as well. But I think it's reasonable to go ahead and radiate. I don't know that the risk is only local. I do think that there is a systemic failure risk that's very much alive in these sort of cases. So,
but in sarcoma, there's no strong evidence that chemotherapy forestalls or prevents metastatic disease. So you're basically
So
saying
maybe
he's
I
got
should close
metastatic
shop,
disease.
I think this was
So you're basically saying he's got metastatic disease, so maybe we can delay that. We're not going to cure him, but we'll help him live. Where I'm saying the radiation is potentially curative, so I think we should use what is most likely going to cure the patient. That's what patients want. They want to be cured.
Yeah, totally agree that unless the radiation, so you will cure whatever disease is in the target area that you are going to hypothesize is the only place where the patient is going to fail, right? I mean, cure means patient will never recur outside of this little circle I'm drawing on the image, right?
Right.
So all I was saying is that I'm not super convinced that that little circle is the only area where the tumor is likely to come back. And I think it is, if you look at an intent to treat analysis, like a group treated with chemotherapy and a group that is not treated with chemotherapy, what you say is absolutely right. The average response in the group that is treated with chemotherapy versus the group that is not treated, there may not be a survival advantage, but I would like to say that the only chemotherapy trial that has actually shown a survival advantage when comparing single agent to combination chemotherapy in sarcomas is gem-and-docetaxel combination. When compared to gem alone, it actually does extend survival. Now, whether it's curative or not is a totally different issue, but
I'm simply saying if you trials that in sarcoma that have utilized adjuvant chemotherapy have, for the most part, not shown a survival advantage.
in
So
other
if there is a systemic disease, chemotherapy will not. Because you were making the point that if he has micrometastatic disease, we should give him chemotherapy. I'm saying if he has micrometastatic disease and it is here, he can still be cured. If it's elsewhere, I don't
Right.
think even the addition of chemotherapy will. I hope someday there's improved, and there will be very soon, I know, improved systemic therapy that will cure patients who have already have metastatic failure, but I don't think we're there yet.
Yeah, well, our approach is different. So things are. I wouldn't necessarily be. I wouldn't necessarily. So this particular approach of generalizing that particular group is a dangerous one. In very good quality of life patient who is performing really, really well, we tend to offer it because the number of patients we kill with gem-and-docetaxel is very small, and the collateral damage that comes from going through the therapy is very small. And if the risks of systemic disease appearing is quite high, we put it to the patient. This is not something that we recommend very trivially, like, hey, you need to get Gemdax, see you later. It's a very involved discussion that involves a lot of time where this lack of evidence is actually presented and why there might be that sort of a lack of evidence and whether they want to go into it. So, and it might be the salesman in me, but most patients usually opt for it because the downside of not having tried that and trying it at a later time does not make a whole lot of sense to them, and that's usually how it eventually gets sold. But you're absolutely right. Based on the evidence that we already have, we should not be giving any additional chemotherapy in this particular setting.
So, may I ask a follow-up question about the radiation and the 3D model? So, now that the tumor is completely resected, you are left with all of the normal tissues of the heart, number one. And then number two, we have this query satellite lesion. So I'm just wondering if you can comment on what you think the field would be in this situation. Would it be the preoperative, where the tumor was preoperatively, or the entire surgical bed, which is really almost his entire mediastinum?
The whole posterior mediastinum, as well as the aorta and pulmonary artery.
And then my second question is, have you ever used your 3D modeling to actually estimate where that positive margin might be, and not necessarily in sarcoma, but in any situation?
I would target wherever the tumor was, and I would target the draining lymph nodes. Station 4 is not, distant from the tumor,
No.
So that would not require me to increase my volumes extensively. I would not chase after other draining lymph nodes because I think it's unlikely that they would be at risk. I mean, if a sarcoma spreads to a sarcomas fail systemically through the blood, not through the lymphatics. So if a lymph node gets involved, to me, that it's not something I'm going to chase after in an attempt to cure the patient. But because stage 3 lung cancer involves targeting all those same lymph nodes, oftentimes they're involved. We're very comfortable and irradiated them to this dose of 66 gray with concurrent chemotherapy. So without chemo, no problemo. You have, there's a lot of esophageal toxicity, obviously, but there's not a lot of risk of major events, luckily. Now, he's had major surgery too, so that complicates things, and he had neoadjuvant adriamycin, so I'm not saying it's entirely without risk, but I feel entirely comfortable doing it.
I would like to point out what this patient really needs is a clinical trial. Because we're all guessing on retrospective and philosophically married to our institutions, and unless you self-train, and then I just do what I want. But we're all have our bias, and this is a group of patients that needs a prospective trial. There's an MDM2 inhibitor trial with radiation, not for the heart. There's a immunotherapy with radiation trial going on. There's a couple others being written. But, the problem with all these trials is they're for resist-positive disease. This is the group of patients that we should be following prospectively with one of these modalities to see if, because, I'm not a strong believer that Gemtax does anything but delay tumor regrowth, and that's all based on the uterine data. All it does is move out the, and there's nothing wrong with
At
living
least
longer.
it's doing something.
Yeah, no, but,
You don't know if they live longer. They just recur later.
Sorry, you're dead on right, unless you're on my new trial. And then we'll talk later when I present it. There is really what we needed between the 3 centers on stage. There is no clinical trial that could not be enrolled with a reasonable N rapidly. I mean, if you think about it, if MD Anderson would commit to doing clinical trials for everything that they ever say should work, along with Princess Margaret,
We're
which
all friends.
no, I'm just saying it's hard. It's just hard. You have to put everything you are going to be willing to do on a prospective trial. And that wasn't a dig at you. I mean, it was just philosophically, you can't just say, well, I've done this for 30 years, therefore it's how we do it. We need to, because we're not curing enough people anyways, we can do better. And so, the volume of patients between these 3 centers is insane, if you think about it. You don't need another center to do a clinical trial rapidly. And so if we commit to doing cardiac tumors, if we admit to doing margin-positive cardiac tumors on trial, you'll have enough to do, a 20-patient prospective trial, and you'll have a signal, because positive margins are going to recur at least half the time, even with radiation.
Would any of you? Oh, go ahead.
Yeah, no,
Professor
I totally agree that I'm not sure about the 50%. In my experience, if it's positive margins, they always recur in the cardiac setting. With the radiation, we don't routinely radiate a lot in the heart because we do go back in for, if it is just a local situation, we like to have the target and manage it with our standard approach where we use both the chemotherapy option, the radiation, and the surgical option together, depending upon where it recurs. For whatever reason, we see a lot of systemic failures in these cases, especially the high-grade tumors. So chemotherapy, trying to utilize it as quickly as possible has been the approach that we have taken. But your point is well taken. I think there is enough number of cases to at least start to examine the approach of giving something adjuvantly if there would be utility. Love to have a target and something to measure while you're giving the chemotherapy. So even at a setting where no therapy is given, and just radiated and the patient recurs, and if it is truly only local problem, it would be fair to go ahead and give chemotherapy at that point with a pre and post measurement to get a sense of whether the patient is responding as well.
Would any of you in your centers want the surgeon to go back and do a lymph node, quote unquote, lymph node lymphadenectomy? No.
Question for you though. Would you be willing to reoperate again later?
After radiotherapy, I'm a little bit leery. I've been through irradiated tissues before, and it's not great. Now this is a mediastinal mass, and we're not actually going to sew heart back together again. To sew tissues back together again, they don't hold very well. Aorta is a different story, but cardiac tissue is a different one.
Because there's one other alternative that occasionally sometimes we use for really bad liposarcomas with
Yeah.
positive margins, which is wait for it to recur and then radiate it and then resect it.
That's what you do there at Washington University?
With some of the liposarcomas.
You do?
Yeah, especially like the ones where they're 100 pounds.
Yeah.
And so you wait to figure out where they're going to recur, and then because 100-pound tumor is not unusual in the Midwest.
Yeah, we've seen gigantic liposarcomas here. One specific.
So this is only the second sarcoma model we've made, so we've never had to deal with that. I'm just trying to think how we would do it. I mean, if we can look at the pathologic sample, and if we can identify the point, we can try to correlate it with the 3D model. Presumably, hopefully, it won't be showing up on repeat imaging now, because that would be a pretty bad sign.
Yes.
But my other one question is, I was just reminded that we do one more thing independently besides Botox injections, and that's hyperbaric medicine. What are your thoughts about hyperbaric sensitization before radiotherapy or in this situation?
A lot of the hyperbaric treatment and concomitant radiotherapy was very popular 20 years ago or so, and I think it's kind of fallen out of favor at this point. Not necessarily for great reasons, but it's not very commonly used. I've never personally done it.
So just a few clarification, because at the end of the day, when we go home today, I'm actually seeing this patient again, and I couldn't tell him that we have discussed and not come with a consensus. I guess like you, Dr. Ravi, I truly believe this is a systemic disease. The value of chemo, although we couldn't prove, we really strongly believe it's there. I guess the issue of the second round of chemotherapy, say with gemcitabine and taxotere, I don't think it will address the issue of the local disease. The question is about micrometastatic disease always. But in some ways, we have also addressed that by giving him neoadjuvant treatment. So if we believe that we gave that for eradication of micrometastatic disease, now we are left with a local problem. How does the adding the second course of treatment helps? Because if that is true, regardless what the clearance is, we should be routinely giving people neoadjuvant, adjuvant.
Yeah. So I was asking that question about the necrosis because of that exact reason. So the original intent neoadjuvantly to give the chemotherapy was to eliminate the systemic presence of the disease. And if your primary mass that is coming out has got significant necrosis, I don't think you need to push the patient further. Okay, but if the primary tumor that was removed has no necrosis and it came out, you have given AI, I'm not sure I've done much about the systemic micrometastatic disease if the primary tumor itself doesn't show any kind of, it didn't change in size, and if at the molecular level there is nothing to suggest necrosis or damage to the tumor, I'm not so sure we really impacted the micrometastatic disease. And that would be my concern. That was the only setting that I would really go into it.
I suspect we don't have much necrosis because it'll be very unusual for the pathologist not to refer to it in the report if they see a lot of necrosis.
No, but it's easy to review, so I think it's worth an email to the pathology team.
We'll do that for sure.
The tumor, if I remember correctly, I've done a few tumors recently, but I think it said the tumor comes to within 1 millimeter of the edge of the lesion. It's unusual a person has such a gigantic tumor with no metastatic disease. Gigantic tumor. And to me, it seems as though you say no. That's good that you say no, because I'm just... What's that?
I don't think it's a big tumor.
That's not a big tumor for non-liposarcoma. For non-liposarcoma.
No, even extremity tumors.
No, I'm talking about in the heart.
Oh, yeah, no, but I mean, just... I don't know.
Speaking to the
heart's-
microphone.
Oh, sorry. Just in terms of size, though, I don't think that that's necessarily. It may be big for the heart, but it's not big for a sarcoma. So we still need
True,
to
but at the
extrapolate.
cardiac
Yeah.
location,
Oh, it's
I
just a
think
bad
is
location.
pretty big. Yeah.
But it had no metastatic disease at all, and that makes me wonder why we don't just irradiate, mop up the bed. I don't know. I'm just a novice in this whole thing. That's why I wanted to invite you guys and discuss this particular
Well,
case.
Charles is not here, but I believe the man is due in clinic next week. So we'll have a lively discussion, I'm sure.
Okay, so good luck with telling what the result of the discussion was. Why don't we move on to the next case? We'll just, let me see where it is over here. That was a great discussion of a real case, and this is another discussion of another real case. If I can find where it is, Watson PM conclusion here is right over here. So he's going to remind you all about this case. Maybe just go down to the floor so you can see. Just go down to the seats over here so you can see what the lesion is, so they'll be able to be able to discuss it.
So just so briefly, just to recap, this was a 49-year-old previously healthy gentleman presenting with shortness of breath and exertion, recurrent pericardial effusions which required drainage, pericardial window. Ultimately diagnosed with metastatic angiosarcoma of the right atrium. He had mediastinal lymphadenopathy and small bilateral pulmonary nodules. So our approach then, or how would you best approach this patient? Oh yeah. So okay. So obviously we discussed it at the Tumor board. Obviously, a multidisciplinary input here is paramount. So we discussed his case, his imaging, his pathology, both in house and in our virtual tumor boards. The outcome of that was he was inoperable at this point, but proceed with doxorubicin, ifosfamide. He had a good response, a small decrease in the tumor size after 2 cycles, and again a further decrease after 6 cycles, but there was still non-resolution of his metastatic disease. The mediastinal lymphadenopathy had decreased, as had the pulmonary nodules, but they were still there. So again, he wanted to be aggressive. So what would you say to him at this point? So we met him again and offered gemcitabine docetaxel. Again, had stable disease halfway through, but unfortunately, after 6 cycles, towards the summer of 2019, developed pulmonary nodules that were new. We started to think he was becoming a bit resistant, and we feared this was really beginning to take off again. So at that point, as Dr. Jones discussed earlier, we considered a phase 1 clinical trial. We are fortunate here that we have a large phase 1 unit. So we looked at the Alchemist trial, which is ALK 4230, which selectively binds IL-2, stimulates the immune response, given in combination with an anti-PD-1. He tolerated this well, with some side effects along the way, but unfortunately, after 6 cycles, again, the right atrial mass had increased in size.
So just to be clear, when he progressed on this study, we actually took him off without resist progression, but the disease was growing, and because it's in the heart, and the treatment is highly toxic. They get Rigos, they get it's an IL-2 analog. So we thought the balance is not in the best interest of the patient to continue on. But what is interesting, if you look at the timelines, this man presented with metastatic disease, and it's now 1.5 years. He's a practicing lawyer, has a band, plays the drum, and is a black belt guy in karate.
When he failed in the right atrium, what happened with systemic disease?
So when he failed gemcitabine, the primary, the progression at that point at gemcitabine was mainly lungs. When he failed this one, it is mainly in his heart.
But did these disappear?
No.
Okay.
At no point did his metastatic disease disappear. And, although he's got small volume metastatic disease, they are numerous. So that was what has limited us for a long time with this guy.
Yeah, so again, treatment options then, most recently, he was commenced on liposomal doxorubicin, has received 2 cycles to date, awaiting restaging scans, so hopefully this will give him some benefit also.
So I have a question. Why wouldn't you want to reintroduce dox and ifosfamide as combination in this setting? And secondly, if you believe there is at least some effectiveness to the IO strategy that you've been put into place, would you consider using something like Taxol, which doesn't totally ablate off your T cell clones?
So the short answer to that is we had a number of options we can take. The choice of going for Calyx is because one, we can access it. Usually we can't. So when we can grab it, we did. The second reason is we have already, in our eyes, reached his maximum dose level. But he was taken off dox IFOS not because he didn't respond to it. It's just because he has reached maximum dose and he didn't have complete resolution of metastatic disease. Where there is a problem, and this is the part that we didn't tell anyone, is that he is a lawyer in a place called Sault Ste. Marie. He flies in, and it takes a lot of effort. So when we spoke about giving him an adriamycin-based therapy again with ifosfamide, he was very reluctant because, every time we do this to him, he's still working as a lawyer. So there is a limit to how much he can work from home or from hospital, as we call it. So this is a real compromise for him. Sure, taxane is another choice that we have in hand. He does not have insurance, so it is a bit of a difficulty. He belongs to the 80% of patients that we see who do not have private health care. So there are drugs that we cannot tap as well.
So I have some Canadian questions. Is pazopanib available here?
Yes, if you have funding for it.
Okay.
It's not funded by the universal healthcare system.
And have you figured out if he has a POT1 mutation or a KDR mutation?
So he was profiled by a different pathway altogether because of his study. There was no actionable mutation, but you were asking for which mutation?
So there's no mutations in POT1. No, nothing to do with that.
If he has, I would remember it because I couldn't recall any patients with POT1 mutation.
And Robin's trial that he didn't present at ESMO, even though he's the first author because he left, basically the endoglin antibody, all the original phase 1 trials were probably, all those responses were probably in the KDR subset where basically you're drugging a driver. And so, this is, the angiosarcoma is 14 diseases, and this is the most complicated one.
So I think I have a comment about that. I do agree pazopanib is a viable. So there are many agents here. In this patient, the question is not whether we should use this or that. It is just a question of sequencing. This patient will see all the available agents for angiosarcoma and likely will not survive this process because he's really used up the most common agents that induce CR and fail those. So what's going to end up happening with this particular case is that you'll see pazopanib and Taxol. So if you just look at it mathematically, you would move taxanes a little higher up on the spectrum because the response rates might be a little bit better with taxanes than the PAS. But eventually we'll see pazopanib. Eventually we'll end up seeing the Winblast and propranolol data, which I don't think works. And everything you can find, because once you put the hat on as taking care of the patient, you can curse the propranolol data, but I prescribe it routinely at the end of the line because you don't have anything else to give. So I think the question of sequencing should really be driven by the likelihood of response, and then the more likely to respond agents, you want to move it up, and the less likely ones like eribulin or propranolol, Winblast, and methotrexate, you would move it further down the road. And that's how we would generally manage it.
And I'm in complete concurrence. The only other thought I have is if he's only failing in his right atrium right now, could you just radiate it with Taxol? Because I do that a lot.
Yeah, you could.
Because that will give you the local control, and you're in a window where you can go after local control. The anti-PD-1 is still there.
Right.
And so if you're going to do it, I would do it now, in the off chance you get an abscopal effect, and then you can write it up and be famous. You're
I
already
think,
famous.
I
though.
think there's an argument to be made of using radiotherapy up front with this patient with paclitaxel. Because, you know, I showed those case reports of patients exactly like this who had good responses. They ultimately died of their lung disease, as this patient will. But, you know, in as much as angiosarcoma in the heart is similar to angiosarcoma on the scalp, realize the biology is different, but angiosarcoma generally is very radioresponsive. So I think if there was any chance, as you said, of a CR, let's say with the smaller lung nodules, the biggest bulk of tumor is still in the heart. That's where most of the clonogens are. So if you're going to get lucky and give a systemic therapy that is able to kill the, you know, billions of tiny little clonogens in the multiple little lung mets, you want to add the best local therapy right here. And I think that I think that would probably lead to the best outcomes, because it would prolong the periods of time in between you needing to institute another chemotherapy, which is being done because this disease is progressing, but you would halt progression, at least in the heart, with radiotherapy.
I guess he just got his chemo, I think, the week before next. So if my calculation is right, he's coming to see me again next week.
Great.
He usually comes on a scan on his third cycle. So if he's progressing in the lungs, probably the situation is a bit different. But if the primary site of problem is only the heart, then I think we're open to
Well,
the
I mean,
idea.
I agree, but
Yeah.
if he's going to go into, if he's going to become hemodynamically unstable from the heart, that might actually still make sense to radiate there, even if his lung tumors are slowly growing.
Cool.
What about irradiating his lungs as well?
Well, when there's a few lung metastases, no problemo. When there's innumerable, or even more than 4, it's not. It's feasible, but the question is, what value are you really adding?
That's what I was asking.
So I think that stylistically, this is a great opportunity for a trial, because I would not have done this by my bias, and it's purely my personal bias. I would have started with gemdocetaxel, not AI. And this is just out of my series. And that gives you your first randomized trial that ties to, because I do gemdocetaxel for 4 cycles and then paclitaxel radiation. Take out the primary. And then occasionally throw in some immunotherapy and pazopanib, and you end up with these wild concoctions that I can put together in the US that's harder to do, but then you get 5-year durable CRs occasionally. You do with AI too, but this gives us that opportunity to use the registry, tie it to a practical trial, right? Is AI the right thing when these are so responsive to taxanes? Taxanes can be used with radiation with no fear of doxorubicin. You know what I'm saying? Because the danger in stopping AI to radiate is that there's no systemic control in the middle of it all, right? And so this gives us a kind of that working early trial opportunity for your registry with only 7 data fields.
So we've got our first project for the database.
So we've not really radiated for metastases in the lung that are diffuse, but I do agree that in the localized progression in that one area, we use radiation all the time to try to put it to some, especially if the patient is on an immune strategy. There may even be a case to be made where the combination might actually be useful in generating abscopal effects and even releasing some antigens that the dendritic cells there can work with. So I think there's lots of synergy in that particular setting to use it. But I don't recall us ever doing in the metastatic setting. My radiation colleagues are not super interested in venturing into that particular space.
I think it should be, the decision to do that would be made on an individualized basis.
It should be made on trial. I mean, this is something where, you know, do we not do this because the only people that see at least an angiosarcoma a week are you and me? I mean, is this something where, because they're very diffuse, there's only 300 in at least the continental US, and plus, what, the 100 that happen up in Canada, that we just haven't tried it? I mean, this is why this, I'm just pushing us towards ideas for trial, because, you know, the data in Ewing's for whole lung radiation is solid. Angiosarcoma in the beginning it acts like Ewing's in terms of response. And so are we missing something that we just haven't tried because the patient volume wasn't there because we're not pediatricians that only see 4 diseases? Present company accepted.
Are these tumors after they go through chemotherapy still immature? How did they change, Brian?
No one knows.
Yeah.
I mean, do you have data plus or minus treatment on evolution and angiosarcoma?
I'm sorry, what was the question?
He was saying that they're like Ewing sarcoma. They're immature. They respond to chemotherapy, radiotherapy, and stuff like that. After you've given a few courses, like this fellow here has had different hits of different chemotherapeutic agents, is it still as immature as it was before?
So the line of therapy is super important. So the best place where we learned that lesson the hard way was the Trachon Trial, right? So the Trachon Trial randomized between pazopanib on one arm, pazopanib plus the endoglin antibody, TRC-105. The combination is clearly active. The reason why I say this is I've actually pushed patients who progressed on pazopanib on the pazopanib antibody combination and elicited responses, while the antibody by itself does not produce a response. So clearly active second agent, and the combination does work. And the phase 3 trial failed. And one of the reasons why the phase 3 trial failed is that the control arm, which was pazopanib only arm, performed exceptionally well compared to what historic data we had in pazopanib. The reason why this happened is the enrollment strategy only included patients with first or second line therapy, which pazopanib is never used first line or second line. So they based the control arm's activity on the basis of third or fourth line use and estimated that would be the activity on the control arm and expected the experimental arm to do much better. But when that trial actually rolled out, people started using pazopanib in the first and second line setting, and lo and behold, the activity was much higher and the difference between the two was quite limited. That was one of the reasons. So the best pazopanib data, if you want to find out, is this negative trial. Control arm shows the best result. The Meg von Maren's angiosarcoma phase 2 trial in pazopanib had 0 responses, mostly just some stable disease. Most of the patients just progressed. But on the control arm, several responses. So earlier use of pazopanib may actually have better outcomes.
And I'd like to point out that if you actually look at those curves, it's not a negative trial. There are 20% of people that do exceptionally better, and no one is bothering to figure out what's different about them. That has a tail of the curve that is a year difference,
Right.
and nobody's putting the money in to figure out who that 20% is.
Median time to progression was 11 months, so,
But
which
you-
is longer
but-
than any of the other ones.
Yeah, but
we
you
put
also
on
look at the
board.
tail of the curve, and there is a clear subset.
Yeah, no, I totally agree.
And then because it's just died.
It's a huge missed opportunity, a trial that really could have been so much more, that ended up the way it did. Because of heterogeneity issues, they included both visceral and cutaneous disease. Should have never particularly done that. And measurement of response was a royal pain as well for the skin-based lesions. They don't shrink, they actually fade off. So when you're making measurements, it looks like it's stable disease, but any child can tell you the whole thing is disappearing, but the outlines are still the same size. So you are underestimating benefit, and difficult disease, it becomes a huge issue. So.
May I just ask, in your experience, the role of IO in the absence of radiation, and it's interesting actually here in Toronto, the Princess Margaret publishes kind of this pamphlet every year, and it was all about immunotherapy. And so when that came out and Albie was on TV talking about immunotherapy, and then every single patient came in asking for IO.
What's IO?
Immunotherapy.
IO?
Immuno-oncology.
Oh, there you go. Immune oncology. Okay.
So I think it's hard to talk about this patient, but like cutaneous and radiation-induced angiosarcomas, there's clearly a role for IO, and it's a debate of whether or not to use atezolizumab Pembro or Ipi-Nivo, and I fault to Ipi-Nivo because I see the best responses. I have had in my limited, when I get to it, I've had complete responses, but it was within the curative setting. This patient's already sailed. So, we went and saw that we had great control with chemo, but I'm also jumping ahead. I jump ahead because we're involved in all the trials that are coming. So like a TKI with Ipi-Nivo works better than a TKI alone. And so like Cabo Ipi-Nivo or Pazopanib Ipi-Nivo if you're brave and not worried about hepatotoxicity and you can tell the difference. And I'm not afraid. This is people with limited lifespans, right? You can see these amazing durable responses, but not after they've failed.
So what line of...
It's part of frontline combination therapy. If you're successful, I keep pushing, right? You only have one chance when you don't have clonal. You need to prevent clonal evolution before you start introducing IO. If you can treat to measurable, seeable, non-growing disease, you put it in then before you have 50 different clones, where the immunotherapy may take out 25 and the other just grow.
I think right now we've probably treated about 26 patients with angio on this, and our experience is very similar.
What kind of angio?
All kinds. Cardiac, we have treated one case where it prevented recurrence in cardiac angio for about 8.5, 9 months, which is unheard of in cardiac angio as monotherapy because these things recur even before the wound can heal, typically if there is metastatic disease. But in the cutaneous setting, in the UV signature angios, it's clearly very active. It will induce a CR-like picture, but the cells are still there. We've done random scalp biopsies in these patients to see if we can stop the pembro. I have a guy who's now about on dose number 65 on pembro. And we wanted to stop, so we did some random scalp biopsies and can actually see tumor nests in the skin that is not apparent. It's normal skin, so I don't think you can stop it, but it is certainly its quality of life is excellent, no toxicity, and doing really well.
So this is a limitation of the Canadian kind of healthcare system, or at least, we just don't have access to any of these agents for people who do not have very, very, very good private drug coverage, especially in the absence of published data.
This case, when we started, no one would pay for it either. So we actually used a philanthropic account to pay for the first 3 doses. And when there was benefit, we negotiated with BCBS, which was a totally crazy conversation because they wanted a study. And I was trying to tell them, don't worry about the study. This patient is responding. It's the experiment in the patient that is working. Please support the drug. And eventually they picked it up, and there was a small cost, which was written off by Merck. So you can also use the patient assistance program in rare conditions to get access.
So does BMS not have the same patient's assistance program? Because I give away more immunotherapy than I should that in Canada than it does in the US, because it's amazing for sarcoma.
I don't know.
So because sarcoma, IO does not have a designation in sarcoma at the moment, they cannot offer compassionate access program. That is true. So theoretically, you can apply to the province to say, here's a patient, this is within what we know. If you take an ASPS patient, unfortunately, the decision is not made by the people who know this disease, and they invariably would say no. So I've sort of stopped doing the paperwork because it's a lot of my time for no return. The kicker is this: if you start that treatment before they say yes or no, So even if they say yes and they discovered you have used the patient as an internal control, they won't fund it. So there's some crazy bureaucratic laws. But I'm not going to change the Canadian system, I think. But the beauty that we have is a large clinical trial portfolio, especially within the phase 1 group. So we routinely use that. So our experience at the moment in angiosarcomas, if it is visceral, you could almost forget it. We don't get a response. Cutaneous, perhaps, but that's it. The last patient that we treated with cutaneous angiosarc a few weeks ago failed spectacularly, Saba's patient. So, but we just bear in mind that I think we are selecting these patients a bit more. Furthermore, even in phase 1, it's very hard to find unselected spots. As the science of immunotherapy becomes a bit more, finite, they are, it's very hard to find an all-comer study. You could hardly find sarcoma phase 1 studies, and then you're banking on these cold tumors or no CPI designated, no checkpoint inhibitor designated studies, and you try and exploit that. But our success rate is not bad. Last year alone, we put 32 patients onto for our sarcoma patients into a phase 1 program, right? And that's our number, 20 to 30 easy. And last year, because of DAPR, we actually doubled. So that's not excluding DAPR. For 2019, if we put DAPR, we have over 50 patients getting checkpoint inhibitors. But it is a struggle.
Can I bring you back to the first case? Should we have done something differently with respect to preoperative chemotherapy in this fella?
Actually, could you have done preoperative radiotherapy?
Is that what you meant?
Chemo or radio?
I would say that this is a patient with metastatic disease where you never.
No, not this patient. The earlier one, the one with the big tumor. This guy here, the one with.
Oh, that one.
That one there.
No, I think that would have been our approach as well in terms of.
Give him a little bit of
starting it. chemotherapy.
Didn't make any difference. Go and cut it out.
No, I mean, it was standard of care chemotherapy that you used. The only difference that we would have probably done would be to use functional imaging to get a sense of, is the response even happening, or is it really totally static? And if it were to be static and it's not growing very rapidly, would have switched out to Gemtax to see if that can induce a response before the surgery actually happens. That's the only thing we would have done differently.
Did you go into this with an expected positive margin?
No.
You didn't? Okay. Because, I keep learning from my radiation doctor to give less radiation when the tumor's there.
Oh, yeah. We generally do use a lower dose of radiotherapy
Thank you.
in the neoadjuvant setting.
Thank you.
So there would have been an advantage potentially there, but the offset of that is that maybe there's a higher rate of complications, which in this area is not something you want.
Clearly, there's no right answer here. But I only brought that up to further the discussion.
Some of my head and neck colleagues prefer actually to operate beforehand and then have it resected. Some of my soft tissue surgeons prefer to actually radiate and quickly get in there and operate before the fibrosis and rest of the sequelae begin to set in. Do you have any comments on, from a radiation standpoint, do you have a preference in this location? Is it a pre or a post therapy strategy that you would prefer?
Technically, it's always easier to irradiate when the tumor is there.
Still there, right?
The only times when that is not true is if there's pushing borders such that once the tumor is removed, the area that we need to radiate would be smaller, but that's very uncommon. So it's almost always, technically, it's an easier day at work if I can just target something that's there. That being said, ultimately, my goal is for there not to be a local recurrence. That's the part of the equation that I can control. So if it's better for the surgeon to operate first, then I would encourage the surgeon to do that.
Okay. Thank you very much.
Sorry, I have just one question.
Go ahead.
One of the issues we had with this model was that the model was about a month out from the surgery, I think, that the CT
Right.
that we used. Based on your experience with the growth rate of these tumors, what's the kind of an acceptable timeline that you would recommend to stay within?
A week.
No, this tumor you would be fine because the patient
I agree
had
with that. That was
stable
previous,
stable
yeah.
disease for such a long time, so you're in good But with some tumors, it can be, especially if you're operating without any pre-therapy, they can grow really fast. I have ones that double within a week, week and a half. But usually the goal of neoadjuvant therapy, if you believe in it or give it, is that the tumor has been pushed to a very quiescent state where it is not actually rapidly proliferating. And that's the setting where you will have a little bit more breathing room. So I don't think it'll be an issue to have maybe 2 or 3 weeks, but the fresher and faster, the better.
How fast can you make a model?
Question was, how fast can you make
We
a
can
model?
make the digital model in about under 24 hours.
But truthfully, if a cancer grows back within 2 weeks, you stopping it, you got bigger problems than
exactly right.
than the timing of the model.
Yeah, and that's exactly why the neoadjuvant approach actually is helpful, is that it eliminates these clones that are rapidly proliferating. And if you don't have that, and this has been shown by the group in Harvard and in other groups, that if you operate on a tumor that is progressing, the odds of actually getting a successful outcome is way less than when you operate on a tumor that is still large but is responding to therapy. And the data spans multiple histologies. Just many soft tissue sarcomas do the same thing, and I don't think angios or cardiac sarcomas are an exception to that rule.
When I first started doing this, they would have me do the operation after, I think it was about 4 or 5 courses of chemo and finish off with a couple extra. Now we give all the chemo up front and then operate.
I don't think it's that important to know. I think it's critical to determine, is it working? If you determine it's working, let's say you give 2 cycles and in your rush to operate, go ahead, knock yourself out, get it
And
out. If you can get it out,
give the rest of it
go ahead
afterwards.
and do it, and then give the rest of it post-op. Because the fundamental question that you're trying to answer with neoadjuvant therapy is this
responding?
even working in the first place? And like it was pointed out, it is actually quite a challenge to classify them into the ones that work and the ones that don't. The data on this is very poor because we treat them on the basis of intent to treat. We don't reclassify the groups on the basis of response. So the real question I'm interested in is not if someone who got chemotherapy actually lives longer or not. I want to know if someone who got therapy and had a good response at the first restage, do they actually live longer as opposed to the ones who didn't get that response? And that is a much more useful thing clinically, rather than knowing whether blindly giving chemo works or not in a large group of patients with median survival difference.
Because I think since we don't know how much to give, I think my question always becomes, if I can make it smaller, does it operate or does it change your surgery? When the answer is no, that's when you operate. If I want to give more afterwards, it's fine, but you don't want to lose the window. And at some point, it doesn't matter if it gets smaller because the surgery is the surgery. And so really, you have much more control.
I mean, I do whatever Albie asks me to do, but clearly you see, yeah, that's right. You'll see this.
Usually it's a group discussion.
That's right. So the thing is that that particular second patient, I mean, he's my patient, so I know him well. You saw the tumor at the beginning, a gigantic tumor. What does that person, from a surgical point of view, lose? All of the right atrium, from IVC to SVC, the tricuspid annulus, tricuspid valve, and part of the right ventricle. That's what they lose, and a bypass to the distal right coronary. After chemotherapy, what does he lose? All of the right atrium from SVC to IVC, the tricuspid annulus, tricuspid valve, and part of the right ventricle, and a coronary bypass. I always look upon it. There was many years ago, there was a woman who had a sarcoma in her left atrium, and it was probably a pulmonary sarcoma going into left atrium, and the thoracic surgeon asked me to resect part of the atrium. And I resected it, and it looked like it was fine, but it was a positive resection margin. So I went back and I resected blindly almost all of the left atrium, all of the right atrium, even though it looked completely normal, and she lived 4 more years after that. And so I've always thought about preoperative chemotherapy as spilling milk on the floor. You can wipe it off, but a cat always knows there's milk there. You can't see it, but it's there. Whereas you give chemotherapy and there's no microscopic disease that you can see. So that's why I like to do it. But the resection in reality is always the same. you're going to go wide because you don't know where that stuff is. Yes, you would take margins in the OR, but I'll resect half of the right ventricle, resect a lot of it. We're very, very, Mike is the same way, Mike Reardon's the same way. The surgeons that do this, and there are not very many people, and we have to teach people how to do this, that's why it has to be in very few spots, are very, very aggressive very, very aggressive resectionalists. We're all transplant surgeons. We're not afraid to take out somebody's heart, cut it apart, and put it back together again. But the resection is the same, but I think about it, that cat with the milk on the floor. That's why we wait. I always worry, if it's getting smaller and smaller and smaller, should we wait till it gets completely small and then stops getting smaller? That's what I thought was the best part, but I don't know if that's the case or not. We always have a big discussion
So
about
the beauty of doing AI is, at least here in Toronto, we're limited to the maximum docs level. So by the time 4.5 months, we're done, right? So that coming to that phrase of, there's no fear of us getting too greedy that we push them to the brink of them progressing again. So I guess that's a less of a bigger issue. But if we use other regimens, we have to be very mindful, especially for angiosacs, because their escape, because of the treatment pressures, this disease that we start with and the one that we end with is not exactly the same.
Yeah, you saw that in this patient. The atrium went away and the pulmonary grew. And now the pulmonary is going away and the atrium is growing. It's a totally different tumor. That's what I was asking in terms of, from a metabolic point of view, do you think it's something different?
No, we know it's something different. This is the ultimate person to be biopsying and sequencing. This is the patient that teaches you the most. You had the primary tumor from diagnosis. If we had lung mets from diagnosis, if we had now the primary tumor again, this is the kind of patient that needs the molecular project so that we can actually figure out what we did.